Good morning, everyone. This is a joint Montgomery County Council session of our Public Safety and Health and Human Services subcommittees. We are here this morning to discuss the issue of hospital emergency department capacity and the need for additional psychiatric bed resources, not just here in the county, but across the entire state. Let me provide a little bit of context for the session this morning and begin by acknowledging the incredible, and I mean incredible, infrastructure of hospitals that we have here in Montgomery County. We have 6 of what are undeniably world-renowned hospitals that work cohesively together every day, both formally through Nexus Montgomery, but also informally in sharing and collaborating and leveraging resources. I'm proud of the public health system that we've been able to build over generations and have experienced it myself, as has my family, and I'm sure all of my colleagues as well. So we do have a very strong emergency room system here in Montgomery County in our region. But having said that, that emergency room system has been challenged in ways that none of us could have ever possibly imagined just a couple of years ago. And in a recent ride-along that I had the opportunity to participate in with our fire and rescue team, and all of my colleagues have participated in ride-alongs over the years, I found it alarming that on that particular evening, there was something called a code yellow that had been issued. And what a code yellow means is that all 6 of our hospitals in Montgomery County had gotten to emergency room capacity. Now, that didn't mean that they would no longer take emergency room patients, but what it meant for our system, and particularly for our fire and rescue and ambulance services, is that when an ambulance was called, and if it were a non-life-threatening injury, an ambulance would literally have to wait in the parking lot until a bed was freed up in order for a patient to actually be seen, which obviously stresses our entire system and runs the risk of a significant issue occurring simply because of volume and capacity. Now, as I have since learned, and I want to give Beth Schumann and Linda McMillan, as well as all of the county staff that worked on finding more out about this issue, this is a complex issue. It deals with a few things. The first is the complexity and acuity of cases that we are seeing is really extraordinary, in many ways unprecedented over these last 2 years. We're also seeing a significant increase in mental health issues and cases that are rising to the psychiatric level that are a huge challenge for our patients and our families, and a system that is entirely stressed across the state and not a sufficient number of referrals. We're also having staffing challenges within our hospitals, and those 3 things combined and others are contributing to the extraordinary challenges that we have before us today. Now, we have an illustrious panel before us today to discuss these issues, but I need to mention for housekeeping purposes that we do have a hard stop at 11:30 today. And because of the complexity of this issue, I doubt that we will be able to address all aspects of it this morning. And so we will have a follow-up session before the December recess, which will be scheduled immediately after this session is over. But I wanted to have everyone know and be rest assured that this issue is an extraordinarily high priority for us, and we will make sure that there is sufficient time to be able to move forward. So I also want to note that we have representatives here from 3 of our hospitals, Suburban Hospital, Holy Cross, and Adventist, that we will introduce them individually shortly. And we also have representatives from our Montgomery County government. So this morning will be a robust discussion, and we look forward to hearing more from our incredible hospitals about what they're seeing and what more we can do as a council to support their efforts. With that, I'd like to yield to our co-chair of this morning's session, Sidney Katz, the chair of our Public Safety Committee, to say a few words.
Thank you very much, Mr. Vice President and Mr. Chair of the Health and Human Services Committee. You certainly said it well, and I'm in agreement with everything that you've said. I think we obviously have to thank Ms. McMillan for doing such a fabulous job on this packet. And one of the things, and there were certainly many things that I was aware of and some of the things I was not, but one of the things that truly got my attention is that Maryland typically has the longest emergency department wait times in the nation. In the nation. So as the panel is discussing this, if they could also, and hopefully they had already thought about this, if they could also come up with suggestions on what we need to do in order to change that concern. So thank you very much, Mr. Chair, and I yield back.
Thank you, Mr. Chair. Ms. McMillan, thank you so much for preparing this morning's packet. I now want to specifically introduce the representatives that are here this morning, and you can turn your cameras on now. You should be permitted to do so. From Suburban Hospital, we have Dr. Barton Leonard, the Chief of Emergency Medicine. We also have Greta Cuccia, registered nurse and the Director of Nursing at Suburban. And we also have Leslie Ford Weber, the Director of Government and Community Affairs. From Holy Cross, we have Dr. Coots, the President and Chief Executive Officer. We also have Scott Graham, Director of Emergency Preparedness. And from Adventist Hospital, we have Terry Ford, the President and Chief Executive Officer. We have Marcel Wright, the Vice President of Adventist Healthcare's Behavioral Health Service Line and Shady Grove Medical Center. And we also have Dr. Marissa Leslie, the Medical Director of Psychiatry, representing Nexus. From Montgomery County, we have Dr. Earl Stoddard, our Assistant Chief Administrative Officer, Dr. Raymond Kroll, the Director of the Department of Health and Human Services. We also have Dr. Rolando Santiago, the Chief of Behavioral Health and Crisis Services. We also have Fire and Rescue Chief Scott Goldstein, Assistant Chief of Fire and Rescue, Mr. Peter Friedman, and we also have Avital Graves, the Manager of Mobile Integrated Health from Montgomery County Fire and Rescue. So thank you all so much for joining us. I know there are other members of your team that are on that I may not have introduced, but we appreciate everyone's attention to this issue. We know how hard you're working on it. Ms. McMillan, thank you so much. Who is going to get us started this morning with their presentation?
Yes, Jessica Melton is here also from Suburban Hospital, and Suburban is going to start us off, and I believe that she will introduce her panel, and we do have some slides that will be pulled up for the presentation as well.
Terrific. Thank you.
Thank you, Ms. McMillan, and thank you to the members of the council and our community partners here across Montgomery County. This is an issue very dear and near to the core of our mission of improving health in our community. So I want to thank the council for their attention to this matter and for starting this dialogue today with all of us. I would like to welcome and introduce members of our leadership team here in council who will help guide us through some of the information and facts that we're seeing here in our emergency department. So I'm joined here today by Dr. Barton Leonard, who is the head of our emergency department and our physician leader for our emergency department, and Greta Cuccia, who is our nursing director for our emergency department. We're also joined by Susan Webb, who is a member of our behavioral health team, who will also support questions and comments today. Without further ado, I do want to turn over to Dr. Leonard, who I believe will be walking us through some information this morning.
Thank you, President Melton. Good morning, and thank you also for the introduction, Vice President Albornoz. I do share your sentiment that the day after Halloween should be a federal holiday.
Yes, it should.
For multiple reasons.
Yes.
So I'm the director of the emergency department. I've been here since '99, and I'm very much a community member. My grandfather had patients here. My mother had patients here at Suburban, and I'm third generation. And I want to know, how do we share the slides? Oh, fantastic. It looks like they're being shared. Okay.
And you can just say next, and then they'll be advanced.
Thank you so much. So we'll go ahead and say next to the next slide here. Quick overview, and I realize that we have a lot on the agenda today, so this will just be a broad brush. But Suburban opened in '43, it's basically in response to WW2. It's been a level 2 trauma center since '77. We have partnerships with a couple of our neighbors across the street, NIH, especially with their stroke care, and we do a lot of research collaboratively with them. And then Walter Reed, and we usually have like a trauma resident from the Army or the Navy help them get battlefield ready. Demand for services is very high, particularly behavioral health. Also, trauma has increased. But as I'll talk about shortly, the general overview of medicine, we're seeing all sorts of issues that have cropped up during the pandemic due to a decreased ability to get into your primary care, and also people not wanting to come into the hospital, frankly, because they were scared sometimes to come to the hospital. And then the number of patients seeking care has returned and actually has now exceeded pre-pandemic levels. Next slide, please. Here's just a really good snapshot. So here's 2021. On the left, you'll see just the increase in terms of our volume trend month over month. I included this slide just because it's so impressive. We don't have numbers because we didn't want to overwhelm you with data, but just know that let's see, it was May is when we hit our pre-pandemic levels, and then we just continue to increase. And the trajectory here makes me a little concerned of our capacity. And this is not just the story of Suburban Hospital, right? This is all the different hospitals in the region are seeing this kind of increase. And then you can see our pediatric volumes, a very sharp curve. I can tell you that moms did not want to bring in their kids during the pandemic. And I completely understand that sentiment, but now there is a comfort level that has returned in terms of needing to bring your kids in for acute emergency care. So we're seeing that the kids return. And this is the same story across the nation. Next slide, please. So this is just a snapshot of the last few months in terms of our ambulance arrivals. It was July, we were, and this is versus 2019, so pre-pandemic. So July 2019 versus 2021, we were actually down at about 10%, but since then we've been increased 10% in August and September. Next slide, please. And then you'll see the ambulance diversion hours. And that is what Vice President Albornoz was referring to in terms of, I think you had mentioned yellow diversion. But that is when the hospital goes on diversion, usually due to either capacity. We don't have any critical care beds or any general beds in the ED. And there's a couple different flavors of diversion. We can be on red diversion, we can be on yellow diversion. And recently, especially during the pandemic, we've been increasingly where the whole county is on diversion, and that's called blue. But these are all types of diversion represented in this graph, and you can see a striking trend and a huge increase in terms of the ambulance diversion hours. As Vice President Albornoz says, it doesn't mean that the ER is closed, right? We will still see anybody that shows up, and it's just that if a ambulance calls in, we'll say, hey, is there another hospital that's a little closer that could take care of this? If they're really acute, just come here. But it's a system where we try to get the patients to the best care that has the most capacity at the time. Next slide, please. So as we said, there's been a return to normal and now an increase. And it's mostly because for the last year and a half, frankly, people have not been able to get the care that they normally would, whether it's from their primary care doc or from hospital care. And if you think about it, if you're even the televisits, the physical exam's not happening, so it's still not as good. So even if you've returned to a televisit, you're not doing the same kind of level of care that you did pre-pandemic. And sometimes people were just scared to come in. Other times they didn't have access. So by the time they show up in the ED, they're simply sicker. So those patients are actually staying longer in our hospitals. So the length of stay for hospitalized patients has been longer, which is causing a problem in terms of our throughput. Patients present with more severe conditions because of that. suburban hospital trauma cases have increased 49%. Now, part of that you have to put an asterisk on because we've changed, the county has changed the way that we categorize trauma. So we're including a couple things that we didn't always include before. But even with that asterisk, we have seen an increase in trauma. Then there's been the workforce challenges. This is true in every service line, in every industry. And I'm sure you guys have seen on the news, the nursing shortage has been it had a huge impact across the region. At Suburban, patients are waiting 15% longer in the ED before being admitted to a hospital bed. And then that doesn't even include that they're waiting in the waiting room longer as well. So by the time they get back, it's harder for us to find a staffed bed upstairs, and they're waiting in the waiting room longer. And there's a shortage of beds, both physical and staffed, in the region for the next level of care. Next slide, please. So in that first quarter of the fiscal year, behavioral health needs rose 5%. And although that doesn't seem like a huge increase, our margin our capacity was not huge as a region. So that bump has been really tough because these patients require more staff to ensure safety of both the staff and the patients. And they require more resources in terms of placement, getting them to the next level of care that they need. So there's a bed shortage. There's available placements that aren't necessarily where they'd want to be. So sometimes we have to say, hey, the only bed that's available right now is in Southern Maryland. I know that's really hard for your family to get to or for you to get to, but that's the only one that's available. And this happens on a regular basis. And then when they have medical needs or co-occurring substance abuse, those are harder to treat because you're dealing not only with mental health, but also with physical. And there's legal complexities because there's when you have what we call a placement, so the next level of care for that patient that needs a higher level of psychiatric care, it's a question of, is this voluntary or involuntary? And there's not a lot of what we call involuntary beds in the state or in the county. And then there's the issue of obtaining medical consent and psychiatric consent. Next slide, please. So Suburban has tried to handle these in a lot of different ways in terms of these new challenges. We do have a dedicated crisis intervention team on board 24/7. And those are specially trained social workers that help the emergency department staff treat patients in need that are having a mental health crisis. We also have peer recovery coaches that do a screening, a brief intervention, and a referral to treatment in collaboration with the doctor and with the nurses. We screen psychiatric care while we're waiting, and we will begin psychiatric care. And in fact, at Suburban, what we've done is, knowing that this has taken so long sometimes to get a psychiatric patient the next level of care or a bed upstairs, we will actually have them be seen by psychiatry, by our behavioral health team while they're waiting for placement so that we don't get behind the 8 ball with their treatment. And then we have a separate and distinct unit. That's a picture of just the little sign outside of it that has just a good look and feel. It's their own separate space with security, with specially trained staff, and with our crisis team in that unit. Next slide, please. So a couple solutions to consider. Workforce support. Another one is EMS officers in the EDs. And what they can do is they can help with directing ambulance traffic. And we actually tried this during the pandemic in that first surge, and it seemed to work well. And that was when we had one of the EMS officers stationed at each of the county hospitals to help manage that surge in patients, but also to manage all the extra COVID-related measures that had to be taken. Continuing public health campaigns to get flu and COVID vaccines, also for safety, also for violence reduction. And I want to add one more. I strongly believe that we need a public health campaign for blood donations, because we're actually seeing a huge decrease in availability of blood products, whether it's just red blood cells, platelets, et cetera, to the point where a lot of even our trauma centers have had to temporarily close because we had a shortage in the region, and this is happening nationally. People are just not donating blood like they used to. Alternative care sites for behavioral health patients. This has been talked about at a state level and a regional level about the crisis and stabilization centers, so that some of the patients can be offloaded from the emergency department and hospitals. Detox centers for substance abuse, residential treatment centers for like a transitional health house, and then this geri psych, that just means a geriatric patient that also has a concomitant psychiatric problem. These are very challenging patients, and there's not a lot of specialty units that can handle these patients. The other thing that all hospitals have been doing and all emergency departments have been doing is we're seeing and treating patients in the waiting room, because all of our waiting room times have gone up. And we're doing more of this where we will actually go out, see the patient before they have a bed available, because it's better to at least start care, see the patient, get eyes on, and reassure them that we will eventually get to them. So that's another thing that we're starting to do and get creative with and try to expand our clinical space in that way. Next slide, if there is another slide. No, there is not. So that is my presentation. I know it's a full agenda, and thank you very much for your time and consideration.
Thank you, Dr. Leonard. Great job. We're going to get through all the presentations and then save our Q&A for the end.
Okay.
We're now going to move on to representatives from Holy Cross Hospital. Dr. Katz.
Well, good morning, and thank you very much for this opportunity. So Holy Cross Health is a regional healthcare delivery system which operates 2 hospitals here in Montgomery County, Holy Cross Hospital in Silver Spring and Holy Cross Germantown Hospital. And we also have a network of community facilities and programs, including our 4 health centers that care for the uninsured and vulnerable residents. And these health centers are located right at the Silver Spring Tacoma Park line, in Aspen Hill, Gaithersburg, and in Germantown. So both hospital emergency departments and our health centers see patients with a range of mental health issues. And in all of these settings, Holy Cross Health has experienced an increase in patients with mental health conditions. So both emergency departments are returning to pre-pandemic numbers as well. At Germantown, the ED behavioral health volumes have increased 12.6% since 2017. The length of stay for behavioral health patients has also increased from 8.1 hours in 2017 to 15.95 hours in 2021. And the average daily census of behavioral health ED patients in Germantown has increased from 1.3 in 2017 to 2.2 in 2021. And remember, Germantown Hospital also has a 6-bed voluntary unit attached to its emergency department. At Holy Cross Hospital in Silver Spring, the ED behavioral health volumes have increased 10% from 2017 to 2021. Emergency petitions have increased from 458 in 17 to 741 in 2020, which is a 62% increase. Our involuntary patients have increased from 140 in 2017 to 330 in 2020, which is a 136% increase. And really, our high point was just this last week, where we saw 23 behavioral health patients in one day in our emergency department. This year, the average length of stay is 34.5 hours for behavioral health patients, which is an increase of 138%, and 10.1 hours for substance abuse patients, which is an increase of 43%. Of all, however, the worst length of stay is for adolescent behavioral health patients, and we actually measure this in terms of weeks and not in terms of hours before they can move on for placement. In Holy Cross Health Network health centers, the demand for behavioral health services at our 4 centers has increased throughout the pandemic. The dual impact of the pandemic on patients' health and economic status has led to an increase in depression, anxiety, and adjustment disorders, as families have been forced to adjust to the loss of a loved one, as well as loss of vital family income. So each of the 4 health centers offer behavioral health counseling through licensed clinical social workers, including pediatric counseling at our Germantown location. compounding this capacity issue is in the emergency departments is the lack of beds in long-term facilities. And further, we're concerned that there are not enough community resources available to discharge patients who need ongoing clinical and social services support. So it's not enough just to see them in the emergency department, but when they're discharged, they need to have some sort of safety net, some sort of catch capability that can provide them continuing care on a community level basis. And I do want to point out, of course, that all 6 hospitals in Montgomery County are part of the Nexus Montgomery Regional Partnership, which has invested more than $2.5 million in HSCRC funds to expand behavioral health capacity into community level. And Dr. Leslie from the Adventist system will actually talk to this a little bit more in depth here shortly. So at this point in time, I'd like to turn it over to Scott Graham, who will offer our recommendations for some solutions to the mental health crisis, particularly here in the community.
Thanks, Dr. Coots. Chairman Albornoz and Co-Chairman Katz, thank you. And it's great to be back before the council. And I think this time I bring the luxury of having the pre-hospital experience and fire rescue experience, and now with my time in Holy Cross Health, understanding the complexities of capacity operations management in our emergency centers. Over the last couple of months, Eileen Cahill and I have had the opportunity to meet with Dr. Stoddard, and just recently I met with Dr. Stoddard, Dr. Santiago, and Lou Damiano, who is the president of Holy Cross Hospital, to discuss one of the couple of things that I'll offer to you as solutions today, and that's a stabilization center. Back probably 2 administrations ago, this discussion began with creating a stabilization center in Montgomery County. I know members of that delegation traveled to San Antonio, Texas to see what would be a model of stabilization centers. The stabilization center would allow our law enforcement officers and our fire rescue personnel to transfer or to transport behavioral health patients that have no medical immediate need, that they would be able to be seen by a behavioral health team, psychiatrists, counselors, and actually have the ability to house them for a period of time until they were exactly that, stabilized. Whether it's a crisis of a young person who's experiencing difficulties in the home, police are called, the child is brought to the emergency department. The stabilization center would probably be the best place because they could have immediate intervention by a psychiatric team. Is that they went off of their medications needed to be adjusted. So I would strongly advocate that we look together for solutions with the stabilization center. The footprint for such could be existing right now in Montgomery County, whether it's vacated healthcare space, whether it's vacated county owned or county leased space, that we would be able to put this together as a team. And I think that would also help us reduce the numbers of behavioral health patients that are in an emergency department that belong in a very short-term stabilization environment for behavioral health issues. The second thing, and our colleagues from Suburban alluded to, was what through the pandemic, and I'll use fire rescue jargon, EMS 700. EMS 700 was a air traffic controller, if you will, for our ambulances in the county. And we strongly advocate for the funding of that position to be in our 911 center that would have a holistic look at all of our emergency medical services units in the county and be able to redirect them to appropriate levels based on capacity, based on acuity of care. And that person could be a licensed healthcare provider, but I also firmly believe that it needs to be a licensed emergency medical services provider that understands the state protocol and they're able to direct units. And that way, one hospital is not being overloaded than another. There are protocols in place that would allow for EMS transport units to transfer to another hospital, another appropriate facility, so long as it's not more than 20-minute transport time, for example, to that next facility, providing that they are stable enough for that. And then lastly, I would recommend as a solution that prior to the pandemic, we worked closely with fire rescue in developing what's called the alternate care destination protocol. And that would allow county fire rescue resources to transport patients to vetted urgent care centers that have the capabilities of obviously the appropriate staffing, minor imaging, minor pharmacology lab that would be able to take a certain priority in a very prescribed patient that fire rescue personnel would be able to offer them transport to the urgent care center or alternate destination. With a more robust education, county education campaign on that, I believe people would understand that they would be able to go to an urgent care center, receive very appropriate care, and more than likely be in and out of that urgent care facility in much less time than they would an emergency department. All of that said is to help us manage the capacity within our emergency departments, leaving our emergency department beds available for more severe needs of our county. One of the programs that we have begun here is every other hour we round on every patient in the emergency department that's been here more than 2 hours, and we figure out why. Is it imaging? Is it lab? Is it placement? Whatever that is, and we continue to churn that in order to make beds available for us. And lastly, we're working with our commercial transfer partners to be able to discharge patients back to long-term care facilities, skilled nursing facilities from inpatient. That way that frees the inpatient bed much quicker for our emergency department patient beds. So solutions we offer, the Stabilization Center, I think is something that we feel very important for the county to pursue. And we stand ready to assist in working and continuing to work with Dr. Stoddard and Dr. Santiago. The EMS 700, or the air traffic controller position, if you will, at fire rescue at the 911 center, I think is going to be a very vital piece, and the public education piece. So again, thank you very much for your time, and we look forward to working with all of our partners to solve this.
Thank you very much. Appreciate that. And again, we'll get to Q&A after all presentations are done. Next, we're going to move on to Adventist Healthcare, and we're going to start out by hearing from Mr. Terry Ford, the President and Chief Executive Officer. Mr. Ford.
Hey, good morning, council members, and thank you for your interest in this particular topic. This is very important to our community to do this well and get it right, and we welcome and value the conversation that we're having today. Adventist Healthcare operates a White Oak Medical Center in Eastern County, Shady Grove Medical Center, a rehab hospital, and as you know, recently we opened up the Tacoma Park site to be a regional resource for COVID-19 patients. We're contracted with the state to maintain that through the end of March, and indeed that has been a great specialized center to help relieve some of the focus at our other hospitals so that we can aggregate the COVID patients and serve them there. We've been a long time committed to behavioral health in our community, and I wanted to share with you, there's kind of 6 primary areas that we focused on in the area of behavioral health. At Shady Grove, we have a large inpatient behavioral health licensed bed count. We have well over 100 beds that are focused for adolescent, all the way up to geriatric patients. We also operate our county's only involuntary admission unit for behavioral health. We have a partial hospitalization program, outpatient counseling and therapy. We operate the Laurie Center for Children's Social and Emotional Wellness and Early Childhood Development Programs. This is a specialized location for children that need extra help and don't do well in public schools or child care centers. We also operate the Ridge School for grades 6 through 12 with children with learning disabilities and emotional and behavioral health condition. And finally, we operate a forensic unit at Shady Grove Medical Center for victims of abuse in our county. As my colleague said, there's really 3 challenges we're all facing across the country, in particular, also here in Montgomery County. Staffing challenges right now, coming out of the pandemic. We continue to see a lot of retirements from nursing and specialized clinical staff, as well as being recruited to other parts of the country that are still seeing high COVID-19 census levels. The agency staffing recruitment has been strong still, but I do see that waning as the pandemic levels decline, hopefully over the next few months. Our acuity at our hospitals still remains high. I've been tracking this across the country. I've seen an interesting stat. About 20% of patients that need healthcare continue to put off healthcare. And if that's true, if that's a realistic statistic, it kind of speaks to what my colleagues were saying, that when we do see patients, when they do come into the ER and put off healthcare, the acuity is much higher. And the lengths of stay go up when that happens. Longer times in our hospitals are a direct result of putting off healthcare. And so very important to continue to advocate and educate screenings, family practice, primary care visits, and getting access when you need it. Our volumes are growing as well. We're getting close to pre-pandemic levels. However, that's being offset by the challenge of staffing. And so we are putting a number of strategies into place to continue to gear up and respond to both the retirement as well as the national recruitment of our team members. I do think that there are really two big challenges that we face in our state relative to longer wait times and in our county. I won't repeat what my colleagues said, but I just want to affirm what they said, that there are solutions out there that other cities and jurisdictions have put in place to deal with it. Just again, another statistic, about 15 to 25% of all visits to an ER don't need to be seen in an ER. The ER is not the solution for all types of visits, but you have to have something that can replace that. We have to create an educational campaign, and a stabilization center that was mentioned as a great solution to think about. I'm joined by Marcel Wright, our Vice President of our Behavioral Health Service Line, and Dr. Marissa Leslie, our Medical Director, and she will speak on behalf of Nexus. Right now, I'd like to turn it over to Marcel to provide some additional comments this morning. Thank you.
Thanks, Terry. Appreciate that. To our council members, appreciate the opportunity. And to so many of the colleagues that I see across here from the healthcare systems, our Holy Cross friends, suburban friends, while it may be sort of three groups, with those of us that are represented, you have 5 of the 6 hospitals within the county. So it's a pleasure to partner and work with Dr. Crowell, Dr. Santiago. It really is a joint effort when it comes to these issues. Again, I will try my best not to be overly redundant. I would surely co-sign quite a bit on what has been shared thus far by Suburban and Holy Cross in regards to our challenges, as well as the solutions that have been recommended. Adventist Healthcare, as Terry mentioned, does play a unique role within the county and in the state. Mental health has been an area of particular passion for Adventist Healthcare for, quite frankly, close to 100 years, back to the sanitarium days at Washington Adventist Hospital in Tacoma Park. If you look at just from an inpatient perspective alone, of the approximately 190 or so inpatient beds within Montgomery County, Adventist Healthcare holds 143 of those inpatient beds between White Oak and Shady Grove Medical Center, primarily most of those being in the Rockville Shady Grove Medical Center area. As Terry mentioned as well, we are the only county provider for involuntary beds as well. And understanding that this is not just a county issue that we're discussing, while of course we're focused on Montgomery County, with our large level of service to mental health, we also serve as the second largest provider in the state and the largest provider in the county. So many of those that we serve are not just from fellow hospitals and county here, but it's very much, behavioral health is very much a regional service. We receive patients from as far as Baltimore, in some cases, quite frankly, out of state, Delaware, Pennsylvania, of course, crossing well over into Southern Prince George's County and DC. So the needs of behavioral health are so much broader that for all of us, regardless of the number of beds that we have, in many cases, we're serving as a bit of a regional provider of services. From a throughput perspective, as we talk through this, it's really, really important to understand that the bottlenecks that occur, part of the challenge is the beginning of the journey starts in the ED, but the bottleneck continues to get bounced from one portion of the continuum to the next. So think about what you've heard thus far in regards to additional length of stay and challenges in the emergency department. To Terry's point, unfortunately, the reality of the community is the ED has become more and more a view of it being the safety net for the community, whether that be the right level of service or not. Some of our greatest challenges are dealing, quite frankly, with agency partners who have identified a level of acuity, whether it be an adult or a child, but children in particular. They are being referred to our emergency department for support, but those same services, DSS, DJS, do not have placement for these adolescents. And so they end up in our EDs for extended periods of time. And I believe, to my Holy Cross partners example, we don't measure those things in minutes and days anymore. They are measured in weeks and sometimes in months. So the overall continuum continues to be impacted. There is so much uniqueness within behavioral health. We talk about a psychiatric patient. It would be no different than talking about individual aspects of the leg that may be damaged in an accident. You have specialties in ankle and specialties in knees and specialties in hips. Well, it's no different in the psychiatric environment. So you have a patient that may come in that be a high level of acuity, an involuntary patient with schizophrenic needs, which is completely different than dealing with a patient that may have mood disorders, or dealing with a patient that's co-occurring between substance abuse and other challenges. It was mentioned earlier, I believe, as well, from our suburban friends about the need for geriatric psychiatric units, which is a very unique population. Adventist Healthcare has the only geriatric psychiatric unit within the county, and we are only one of two within the entire state that serve that population. So the underlying metrics, even within what is shared, is what creates some of the greatest challenges. Specifically, what we are seeing is from a deflection perspective, and we say deflections, we define that as patients who would have met criteria for a bed that we had, but we could not serve because the beds were completely filled. Those deflection data has continued to increase about the number of patients that we can serve. And most specifically, the increased deflections are within the adolescent population and our involuntary high acuity patients from an adult perspective. So in some cases, we are challenged with those two specific populations and our ability to be able to care for them. Of the 143 beds that we have, 30 of those are child and adolescent, serving patients from 7 up to 18 years of age. And so again, this is an area where not only in the county, but in the state, when we start talking about psychiatric services, child and adolescent needs are particularly challenging. And we particularly see the challenges there of the length of stay, for which unfortunately, in many cases, the ED tends to bear. And again, we know that there need to be significant changes in how we think about that. As a whole, again, not to be overly redundant, we have only added to some of the challenges with length of stay as it relates to managing the pandemic. The reality is, with additional admission criteria from our outpatient partners and those that are in lower levels of care, for which may be needed, the additional steps that are required. Some of our crisis beds and other services in the county have set expectations of needing to be cleared from all symptoms for 10 to 14 days. These are all opportunities for which, when a person would meet that criteria, now they are sitting in an ED waiting because of these additional criteria and challenges. Again, we surely would support many of the recommendations and solutions that were provided. As I segue over to Dr. Leslie, as she speaks on behalf of Nexus, I would add an additional large thumbs up to the Stabilization Crisis Center model. We believe that that is probably one of the most promising approaches for the county that I know I have seen in probably the last 10 years of suggestions and ideas. The ability to really be able to serve behavioral health in a separate setting where that evaluation can occur, and then allow for then the appropriate level of care to be identified there versus using the ED, I think is an extremely, extremely promising model, and one that Adventist Healthcare would support as well. At this time, I'm going to turn it over to Dr. Leslie to really be able to speak more to the partnering that's happening within Nexus as a whole from all of our hospitals, and some of the suggestions that we're seeing and challenges that we're seeing there as well. As was mentioned earlier, Dr. Leslie also is a child and adolescent psychiatrist, and I think that perspective of what she sees would be extremely helpful to the committee.
Thank you, Marcel, and thank you to the council for this invitation. It is my honor to chair the Nexus Montgomery Behavioral Health Work Group, and we are well represented actually on this call. The Behavioral Health Work Group is comprised of member hospitals, representatives from member hospitals in the behavioral health space, county behavioral health leadership, Nexus Montgomery leadership, community and state behavioral health partners, as well as emergency and fire rescue medical services. We've been meeting since February of 2021. And initially we met every 2 weeks to make sure we got good momentum and developed a good strategy. And our direction from the Nexus Montgomery board were 3 priorities. 1, to address patients who utilize our services at a high rate, either inpatient or emergency. 2, to connect with the partners in whom Nexus has invested, community partners, to address challenges and specifically address barriers to placement with those community partners. And 3, to provide input on the county's behavioral health crisis response. So it truly is a partnership. And I know that Dr. Santiago's on the call. We get a lot of updates from the county, and we have the opportunity to provide input on one of the best ways to set up and implement a crisis stabilization service, because we all acknowledge that the emergency department is not the best place for an individual or families with unique behavioral health needs aside from medical needs. I'm sure Dr. Leonard can agree to that. I also want to affirm everything that's been said. Some of our specific deliverables are to, like I mentioned, those 3 priorities, but to also look at the barriers to capacity. We discussed the shared pain points, which include the increased emergency department length of stay. And when I end, I'm going to end with a specific story that highlights that.
Thank you.
High ED utilization and difficulty accessing appropriate community and state resources is a common theme. So as a group, we have talked about what are the needs, what are the numbers. It seems as if once the Crisis Stabilization Center opens on 7 Locks, it will not fully address the needs. As soon as it addresses those needs, I think it's like whack-a-mole. We're going to need even more, but we appreciate that it's a start. We also talk about how to address the bottleneck from different perspectives. It's not just keeping patients from being readmitted, but it's also how can we prevent patients from having to go to the emergency department? And Marcel alluded to this. We have community therapists. I am one of these psychiatrists that sees patients in the community. I'm board certified to see children, adolescents, and adults. And as a practitioner, I know that our approach is, if someone is in crisis in our office, we say, you may need admission, please go to the emergency department. Our goal as a work group is to empower our community partners so that we can better serve people in crisis so that they don't always need to go to the emergency department. There are certainly times where they will still need to go, but if with a crisis stabilization center, with more appropriate community resources, with expanded, hopefully wraparound and ACT teams, assertive community treatment that can help some of those severe cases, patients with severe mental illness, we believe that it's a multi-pronged approach to help decompress our emergency departments and also help serve patients and families in need. And we continue to work, we continue to partner, and we look forward to more engagement with the county. So I'll end with a patient story so that we can really contextualize all that's been said. Earlier this year, Adventist Healthcare, Shady Grove Medical Center, in our emergency department, we had a youth, an adolescent, who was with us in the emergency department for just shy of 2 months. 2 months. To the earlier points that were said, we no longer measure this in days at times. We do measure it in weeks and sometimes, unfortunately, months. And as a child psychiatrist, I know that the perspective of an adolescent, it's not like our perspective where we can think about 20 years ago. Every day is important. Every day lost from the learning environment is important and impactful. So this youth it was under DSS care, had just started a new school, had moved to a new group home in under a year. And the triggering incident was not being able to see a loved one, having that request denied. And this youth has a history of severe trauma, really, really severe trauma. Youth was working hard though, trying to get the grades up, experiencing a decline in grades because of the virtual schooling environment. And all of these things combined into an explosive emotional episode that, yes, was appropriately managed in crisis. But once it was time to get that youth outside of the emergency department, because this youth did not need to go to an inpatient setting anymore, it took, like I said, just shy of 2 months. We saw this youth decline. We saw this youth withdraw, lose some of the gains this youth had made. And like I mentioned, this youth was not receiving schooling. Can you imagine not being behind in school for 2 months because you're in a behavioral health crisis? This is why it's so important. And I know that we all agree on this, but I wanted to end with that story because that's what it's all about, helping youth like that and the families and communities that the patients we see in the emergency department represent. Thank you for this time.
Thank you so much, Dr. Leslie. That was pointed and really appropriate and extremely helpful, just to put an illustration on all of this. So in a moment, we're going to hear from our county officials. But before we do that, Councilmember Glass has to jump off at 10:30. Our Fed committee is meeting at the same time this morning and discussing a bill he has introduced. And so he obviously needs to step on to discuss that bill before committee and has requested to say a few words before he jumps off. So Councilmember Glass.
Thank you very much, Mr. Vice President. It's good to see everybody this morning. And I'm just going to be really brief and just express my appreciation for everything that you all, your teams, your networks and systems are doing to keep everybody healthy and safe. And the last 18 months have clearly strained all of our networks, whether it is county government and our healthcare providers, and you all have provided factual and anecdotal information to put a fine point on it. And thank you for being here and for doing that work. And I'll just add one more anecdotal piece to this. A few months ago, in the middle of the summer, a family member of mine was not feeling well in the middle of the night, and we rushed to an emergency room that at 2:30 in the morning was overflowing with residents. And I know and saw firsthand the acute situation that we're dealing with here and the importance of this conversation. So I just, again, want to thank the Vice President and Chair Katz and the members of the committee for organizing this conversation because it has been so important to my family and important to so many others who need these emergency rooms and need your healthcare facilities way more than mine. And so again, just thank you for all the work that you are doing, and I'll get a debrief on the remainder of this conversation. So I yield back. Thank you very much, everybody.
Thank you, Councilmember Glass, and good luck on your bill. We now are going to hear from our county officials. Joining us this morning, we have Dr. Raymond Kroll from HHS, Dr. Stoddard, who is an Assistant Chief Administrative Officer, Dr. Santiago, and we also have Chief Goldstein on the line as well. I will now turn it over to whoever is teed up to speak on behalf of the administration, and we would certainly love to hear from everyone.
Good morning, Council Vice President Albornoz, Chair Albornoz, and Chair Katz. I think I'm just going to introduce. I think we're going to go with fire rescue first, and then move right into HHS to talk about the behavioral health bed challenges. So I'll turn it right over to Fire Chief Goldstein.
Full class.
If they're interested.
Thanks, Earl, and I appreciate that information and the pass. As you all have all well eloquently said, the challenges since The pandemic has cycled to the second wave as we got back into the new normal, and the day-to-day capacity issues as outlined are immense. And Battalion Chief Ben Kaufman's here, and he can pick up and provide information for the group, and then we'll all here to assist with any other questions. Go ahead, Ben.
Hey, good morning. Thank you. It's a pleasure to speak with you all again. And it's really encouraging that council's really digging in and kind of peeling back the onion on this extremely complex problem. So I'll just focus on how this is impacting EMS. So ED, emergency department bottlenecks, whatever the cause, whether it's an increase in volume or a higher acuity, meaning the sicker patients, or an inability to move the patients through the admission process, which includes our behavioral health patients, or staffing shortages. Whatever the cause, over time, it really impacts our ability to clear ambulances. So we have 43 ambulances on any given day. The total length of one individual call that an ambulance runs, we measure that in what we call cycle time. So this cycle time is broken down into segments from the time of dispatch through the time on the scene. And what we're focused on though today is the specific time from the point at which the ambulance arrives at the emergency department until the ambulance clears. And we call that drop time. So they've arrived at the hospital and they're waiting to turn patient care over or writing a report. So our average drop time over the last 6 months has been, we've been above our average at an increasing level over the last 6 months. In October, it was on average 33 minutes, and we're at 55 minutes for the 90th percentile. And that is increasing correspondingly with the cycle time. So over the last same 6 months, our cycle times have increased as well, to the point that it's now taking longer for us to run each individual 911 call, each EMS call. So it's intuitive that while ambulances are waiting at the emergency department to turn over care, those units are not available to respond to the next call. So if this problem isn't addressed or constantly monitored by the EMS system, as the problem gets worse, as drop times were to get longer and longer, eventually we're going to need more ambulances to continue to respond to the next 911 call in the community. So what we do now on a daily basis is we monitor the diversion statuses that the ED administrators talked about when they are super busy. When they don't have an ability to admit patients upstairs, they will go on some diversion, whether it's yellow or red. And then when the county overall gets very busy, when all of the hospitals are in the same status, we'll go on blue. And that's just saying really to the entire system that the whole system is under stress. We've been on blue with more days than we haven't recently. It's especially during the weekdays, it's been really tough with the emergency departments. Now that is a generic, the diversion statuses are relatively generic. It doesn't speak to exactly what the problem is at any individual hospital. So we also provide our crews the ability to see how many ambulances are at each hospital at any time, whether they're on the way to the hospital or actually there, and also how long they've been waiting. So we, in general, try to avoid emergency departments that are on diversion or that have a lot of ambulances waiting there, and those crews will try to find a more suitable hospital for the patients, depending on what their preference is and what the acuity is, what their specialty needs are from the field. We have constant engagement with 2 EMS supervisors who are working 24/7 to manage not only the highest acuity calls in the field, but also to report to the 6 emergency departments and really keep our ambulance throughput where it needs to be, keeping the ambulances at a minimum at each hospital and back on the street to run the next call. We also have alternative destination programs which I had an opportunity to speak with you about back in February. So we've partnered with Adventist Urgent Care, and we have a telehealth, and also Kaiser, and we have a telehealth program to be able to call from the scene and speak to a physician right there on the scene. As I had mentioned before, that program overall really just, it's for a very small subset of patients who have low acuity complaints, they're not even sick enough really to go to the emergency department. They can be treated outside of the ED. But if you have a bunch of those patients that you can avoid going to the emergency department, that overall should reduce reduce the strain on the ED. But really the answer here is the Stabilization Center. And in terms of EMS's approach to that, the Stabilization Center would be would operate under the umbrella of our alternative destination program, and we would be able to transport patients directly to the Stabilization Center and avoid the emergency department overall. And we do believe that that is going to be the biggest the biggest help to the system, and that's how EMS plays into that. And I want to speak a little bit about additional staffing. So during the first COVID surge, Dr. Leonard mentioned that we had fire rescue officers at each hospital, and we did that to keep our ambulances moving through each ED, but they also managed ambulance disinfection, decontamination after a call. During the second surge, we did not have those officers at each hospital, but we did have EMS 700, which Scott Graham talked about. So this is a air traffic controller or a single bottleneck for each ambulance crew who's getting ready to transport to contact this officer and find the best destination. So we've proposed this in the fiscal year 23 budget, and we believe it will get patients the most appropriate destination and help manage ambulance turnaround time overall. While not directly tied to COVID this time, it is we did see good success with it during the COVID surge, and it's been tested. So we think that it will be able to address our current surge. So it's a single position, uniformed, an EMS duty officer who is clinically minded, staffed 24/7. The position would monitor not only all the published dashboards that we provide to the field clinicians, but they're also in direct contact with the charge nurses at each emergency department to really hear what that yellow status means, why are you on red, how many, what's your ability to admit or see behavioral health patients, et cetera. So that position in real time is constantly looking at that and able to direct EMS crews to the right destination, but also help remind crews that they have these other options, whether it be alternative destination transports or the ability to contact that physician via telehealth and avoid the trip to the hospital overall.
Yeah, I just wanted to let you know so that you're not
I think that's all I have, and
yeah.
you can kick it to Avital Graves from MIH if she wants to add anything.
Thanks so much, Ben. The Mobile Integrated Health Program is working closely with Health and Human Services and our partners at the Crisis Center, and as well as Nexus Montgomery and our hospital partners to ensure that we're addressing all of the needs that we can while we await something like a stabilization center. I love that everyone is championing it, but the reality is it's still a few years away. So what are we going to do in the meantime? So that's some of the things that we're focusing on. The Crisis Center has been very open and amenable to allowing fire rescue to potentially engage them and use them as an existing resource that's already standing, that has the staffing in place and the infrastructure. So we look forward to working with them to try and siphon off some of the low acuity behavioral health patients who are currently going to the emergency departments. We also continue to explore ways to introduce telehealth into the field. As Chief Kaufman alluded to, it's a really great resource that I don't think the community knows enough about. And I echo what Scott Graham said earlier, that maybe some education about opportunities for ER diversion might be necessary. I think that if we're going to offer it, it would be helpful to make sure that folks in the public are expecting that when EMS shows up, they may offer you something other than a trip to the emergency department, which is probably what most people expect us to say. We are also continuing to work on connecting the dots. We have done our best to bring together various resources so that we can all collaborate and communicate together on these shared patients, because probably the top 20 or so behavioral health users in the county are not just attacks on the EMS system. They're not just attacks on the hospitals. They're not just attacks for the police department. Everybody is seeing them. The crisis center knows them by name, Cornerstone, Montgomery, et cetera. So we've been working to collaborate together on addressing the needs of those patients so that they're not just cycling in and out of the EDs on a rotating basis. And we work closely with our peer support counselors like STEER to address the needs of the other behavioral health population we haven't really touched on today, which is substance use disorder folks. So a lot of our behavioral health patients have either coexisting or underlying addiction problems. And while opiates are definitely a problem in this county, the majority of them have problems with alcohol addiction. So we're working closely with STEER, who does help us with those folks who have alcohol and substance use disorders. But of course, all of their services are voluntary. And so getting someone to agree to accept rehab or treatment, despite the best efforts of the team and ARTC, Avery Road Treatment Center, Maryland Treatment Center, we have to wait for them to agree to accept the help that they need. So I think all of those efforts together will really help us out. And in the meantime, we're open to any suggestions or offerings of interim locations for restoration center efforts. And I think Dr. Santiago or Dr. Kroll might touch on that as well. Thank you.
Okay, I think next is the HHS team, Dr. Kroll.
Good morning, everyone. Happy to be with you. And thank you, Council, for putting this session together. This is a long overdue and an important session for us. We are coming to grips with a long-standing 30-year trend in the history, especially around behavioral health in the country. Going back to the late 60s and then across my entire career, I've watched the erosion of behavioral health capacity in a variety of different ways. At this point, we're talking about capacity on a variety of fronts. We've heard about the capacity in the emergency departments and in the hospitals and the demand. But I will tell you that there are wait lists in our community providers as well for outpatient services and for psychiatric services. The demand is up. Just for emergency departments, I think we're seeing somewhere in the neighborhood of a 25 to 30% increase in the number of people who show up at the emergency departments for self-injurious behavior or suicidal behavior alone, not counting the substance abuse numbers. Staffing is down. We've heard about the hospital staffing, but it is also down across the system. Folks are having a hard time recruiting and retaining folks at this point. We are faced in the department with a number of folks who are retiring, but who've retired, who've reached retirement age, and who finally decided to take that step. But also the recruitment is a challenge. Across the board, social work is in demand and hard to recruit in the county, across the county and across the region. Yeah, in terms of the Stabilization Center, we've talked about that. I think the points were well taken on Stabilization Center and don't need to be repeated. I will add one thing, that the focus here has been on emergency department diversion and creating alternatives for fire and rescue and for law enforcement to the emergency department use. But I also want to add jails to that conversation. Jails, about 30% of the admissions to jails at this point are folks with some form or another behavioral health challenge. So when we're talking about diversion, it's not just diversion from emergency department, it is also diversion from arrests and incarceration and a spiral of effects that result from that. So we've got to be thinking about that as an issue as well. I think the point about the capacity at 7 locks is well taken, that it is not likely to be an adequate level of service, but it is a starting point, and we do need to think about what we might be able to do as an alternative. One of the things that I thought was a useful thing for us to think about is this issue of 911 and routing. And Chief Goldstein and team talked about it as an alternative, as diversion from EDs, but it's also for us, as we think about behavioral health, of an appropriate routing of calls so that we can manage that as part of our crisis now model. There is some support for the idea of having behavioral health and or healthcare professionals as part of the 911 call center to help triage calls, both on the front end and on the back end. We have to think about a lot of things other than beds in this process, but I would say that residential treatment center beds, we'll hear about from Dr. Santiago, are challenged. For children and for adults, we need to think about substance use diversion. Steer teams represent an option around that. The ACT teams you've heard about. The crisis bed capacity and willingness to accept folks post-COVID in this ongoing space. So during this pandemic is a challenge that we still do need to confront and address. I think the other piece of this is that as I listened to Dr. Leslie as a private practitioner in the county talk about the need about referring folks to the emergency department, one of the things that we see, and I see in my private practice and work with clients is providers saying, call the crisis center, because after hours, call the crisis center. And that has led to an incredible number of folks who are showing up at the crisis center. And I expect that will be a continuing trend for us for a while. I'm going to stop and turn this over to Dr. Santiago to talk you through some of the things that we're seeing and some of the strategies that are hopefully we'll be putting in place in the coming years. We continue to work with Nexus Montgomery and on the development of a stabilization center along with EMS and the police department as well. So I'm looking forward to continuing this conversation and figuring out what we can do now to defer and keep people out of the emergency departments and reduce and increase the access to community services. Thank you, Dr. Steiber. I'll turn it over to Dr. Santiago.
Good morning, everyone, and thank you to Vice President Albornoz and also to Council Member Katz for seeing the need for this session. And the nice thing about being the last speaker is that everybody has said what needs to be said, and I'm just here to restate a lot of the information and hopefully provide a little bit of details. Does everybody see the PowerPoint by any chance?
Yes, we do.
Yes.
Okay, thank you. So I'll start by talking about the Restoration Center that has been referred to by many of you. This is a project that is on its way. What is being done now, where this project will have 16 recliners, 16 beds. Part of the reason why that number is there is because it makes it possible to be reimbursable for a possible operator, a private operator of this the center. Originally, we had in mind a 40 recliner and 40 bed capacity center facility. But we had to scale down for a variety of reasons, and that was one of them. It will be staffed 24/7, 365 days of a year. We envision a public-private partnership. There is a program of requirements internally within the county government. And the next steps are to include the project in the fiscal year 23 capital improvement program. And also we're exploring already some fundraising activities with the state and other sources. We've already started a number of months ago with our congressional delegation. But we also have good contacts at the state for bond applications and envision perhaps some federal resources as well. And we're trying to generate interest from possible operators, operating partner from the private sector, including hopefully some of those that are represented today from the hospital systems.
Dr. Santiago, I think you need to advance your slides.
Okay, are you able to see the slide? I'm sorry, I thought you were. Do you see this one, stabilization room?
If you can go to the next, since you shared your screen, we were not advancing.
Okay, I apologize. Do do you see a slide that says stabilization room by any chance? No?
No, you need to go down to, you need to go to slide 3.
Okay.
I think if you just hit page down, you'll get there.
Okay, I have done so, but not. No movement yet.
No movement. We can still just see the first slide.
If you go to up top, go to slideshow.
Yes.
If you click on that, I think maybe that'll help you.
Okay, here we go. Okay. Do you see a new slide now?
No. Well, Dr. Santiago, maybe if you could just describe the
if you'd like to take them down, if you want to go through the slides, our IT folks can pull them up also.
Okay, do they have access to it?
Yes.
Okay. And in the meantime, I can, okay, let me unshare this.
There you go.
Okay. Thank you, Linda. Appreciate it. You see the stabilization room slide?
Yes.
So what I was getting at was emphasizing what some of you have said already, that the Restoration Center will not be sufficient. So we knew this already several months ago. So one of the steps that we took here at the Department of Health and Human Services and Behavioral Health and Crisis Services was identify other sources of funding. We identified a SAMHSA grant. We just obtained it about 3-4 weeks ago. And this is to create a stabilization room at the Crisis Center. With it's a limited capacity stabilization room with just 4 recliners, but it will be staffed 24/7 with nurses. We anticipate having at least 7 nurses and over 20 staff that come with that significant grant. It's a 2-year grant, but we're already talking about how we create sustainability for that resource at the Crisis Center. Next slide. So what will happen in the next 12 months? We will continue to partner with the hospitals to explore other stabilization rooms or centers. The state is interested in funding. In fact, there is currently an announcement that is due November 9 for peer support specialists for walk-in and urgent care center. So we know that the state is interested in funding this. I understand the funding comes from the American Rescue Plan as well. So I mentioned that's a short-term, long-term. We need to continue to explore and make sure that these services are Medicaid, they're reimbursable through Medicaid and a Medicaid waiver, and we are exploring that. Next slide. In terms of bed capacity that we have been referring throughout this presentation, currently we have, this is a picture with respect to residential treatment centers, which are for adolescents and children under 18. In the state of Maryland, there are 222 private RTC beds, 95 total for children under age of 12. There are 93 public beds. We refer to them as under RICO, 32 in Montgomery County, in Rockville. The average stay that we all have been talking about is 6 months to 1.5 years, and some of them stay even beyond that. Unfortunately, since 2016, over 150 RTC beds in private facilities were closed, and the current average wait time is 6 months. With respect to, next slide, with respect to the adult population in Montgomery County, we refer to them as residential rehabilitation program beds. These are capped for each jurisdiction by the state at 348, and that's the case here in Montgomery County. The current wait list, we have 159 applicants as of just a few days ago, the 29th, last Friday. Current average wait time is 6 months. Next slide. We have some residential crisis beds. These are shorter term, 10 days. The capacity in Montgomery County, we have one provider with about 30 beds. And at the crisis center, we have 4 beds. Next slide. Some recommendations, these overlap with some of the solutions already mentioned, perhaps adding some additional ones here. We believe, our staff believes, that we need to develop additional housing options for adults with behavioral health needs that would serve as a step down from hospital with wraparound services included. These are low barrier access beds. And continue to enhance collaboration amongst behavioral health systems. As Dr. Leslie mentioned, the collaboration with Nexus Montgomery has been amazing and very, very important and critical at this juncture. And almost, I think, a week doesn't pass when there's a new idea, that a new stone that we try to turn with respect to finding solutions. And then we need to incentivize providers to expand RTC facilities here in the state of Maryland. And I think that's it. I could go on and on. This is a topic that I embraced right from the beginning of my tenure last year, about the same time. And there is so much to talk about, but I think I need to stop and go into the conversation.
Great. Well, wow, there's a lot to unpack here. And somebody described it as an onion, and obviously this is a big, pretty complex onion. But I want to begin from this place in thanking all of you for your remarkable dedication and commitment. There is no question that we have a much greater infrastructure here in our community than most others to address some of these complex issues. But obviously we need to do everything we can to address them. So, and Dr. Stoddard, I saw you were about to speak. If you want to wrap up the component of our county officials, and then I'll jump into some questions.
Yeah, I was just going to say, as part of our current CIP process reviewing, we are looking at ways that we might be able to expedite the Stabilization Center either through an interim process or looking at other spaces, as I think was alluded to. But I think one of the big things that Dr. Santiago alluded to at the end is that a lot of these are dictated numbers by the state of Maryland. So part of this is going to be advocacy to the state to increase some of those numbers around capacity to allow us to, get people the treatment they need. Obviously, being in an emergency department is problematic for the emergency department, but it's also problematic for the patient because they're not getting necessarily the mental health treatment that they likely need as part of an ED care portfolio. It's just there's a better space for them, and we need to encourage the state to really play a role in allowing for more capacity in the private sector and other places for this.
Thank you. Chairman Katz.
Thank you. Thank you, Mr. Chair. I couldn't find how to get off of mute. I have several questions as well. I didn't know if you wanted to start with your questions and then go to mine, or we're in a limited amount of time. We only have a half an hour left for the hard stop. So I don't know how you want to work that.
Why don't you go ahead and start, and I'll come in right after you.
Well, thank you very much. First off, this information is absolutely unbelievable, and we're so very, very pleased that everyone has joined us today. And to Vice President Albernaz's point, there's so many areas to look at. And I think it was Mr. Kaufman that mentioned that we need to peel back the onion, and we do. Part of the problem is, and Dr. Kroll mentioned this, that this has been, I guess, dragging on for a 30-year time frame. I think, Raymond, that was your estimated statement. And we're not going to be able to solve this in one day, but we almost need to. This one can't wait, and this one we can't say we're going to get back to it someday. This one is the day. We need to work on this today. The 150 residential treatment center beds that have been closed since 2016, I believe Dr. Santiago mentioned that. Why did they close?
Am I still on?
Yes.
I'm going to ask, this is one question where I will ask my staff to perhaps respond. I know that Regina Morales is here, and she has other staff as well, and they're very knowledgeable as to some of the reasons.
Hi, everybody. This is Regina Morales. Just to add to that, those are private providers that decided to close their beds for whatever reasons in terms of their business process. Some of that may be having to do with the amount of reimbursement that they were able to access for those beds, or it might have been staffing issues or just how expensive it is to keep those beds open. So part of what might be part of the advocacy is looking at the reimbursement rates for those beds and seeing what are the barriers to private providers opening additional beds.
So how much does private insurance or insurance in general fit into this concern?
Oh, this is one of the things, and I don't know who else might want to weigh into this. Somebody from maybe Marcel Wright might want to weigh into this, but for residential, because I think they have some residential treatment capacity at some point. Residential treatment services are not funded generally by private insurance. Generally, residential treatment is a state-sponsored activity. So Medicaid, Medicare covers most of the cost of that. And I believe, if memory serves me correctly, because long-term, especially for children and adolescents, residential services also have an educational component, and some of that is funded through the local school district as well. So the funding for residential treatment has always been complicated, and it continues to be so. I also think that Ms. Morales is right, that at least some of the decisions from the colleagues that I know who run residential treatment centers, some of their decisions have to do with the cost of being able to provide adequate service, especially for adolescents or children who are in residential treatment, because the staffing demands are different than it would be for an adult residential care setting. They're more intense.
Thank you. Mr. Wright has his hand up as well, I see.
Thank you, council member. Appreciate that. And thank you, Dr. Crowell, for that handoff there. I think, I will surely share our experience as an organization that has been heavily committed to behavioral health services. When I started in behavioral health 20 years ago, Adventist Healthcare had over 90 RTC beds, adolescent beds, of a variety of services that were in the community. The majority of them were in Montgomery County, and we also had some on the Eastern Shore. And we continue to watch the limited margin disappear. And we are a very mission-driven organization, but part of our mission is to make sure that the services that we provide are sustainable, and that we ensure that we can do it at a quality level, a level that we're going to feel good about, and a level that the community is going to feel good about. And we continue to see limited increases that in many cases were not even consistent when they did occur, even with basic CPI. And so it became more and more difficult. And so we had to make decisions over time. Really, most of those decisions were made now probably closer to 10 years ago, around that time when we had to make the decision of what are the things that we can do that allow us to align with our mission and as well as to ensure sustainability. And that's when some of those tough decisions were made. The last thing I would say to our chair and vice chair as well, and to the council is, there's been a lot of discussion at the state level in regard to wanting to bring Maryland kids back to Maryland. Imagine what it is for a child outside of the other additional challenges to be out in a location in Arizona and expect there to be a level of family engagement when it comes to really them being heavily re-engaged back in the community that they're from. And yet, while we've heard many of those discussions over the years in somewhat of a circular way, again, the funding and the model to sort of incentivize, as Dr. Santiago mentioned, for providers to open those beds and expand those beds, we have not seen. And so there's a bit of a disconnect. I surely support the theory. I support the idea of children being served as close to home as possible. I think there is true evidence-based benefit to that, but we just have not seen that alignment.
Councilmember, I would just add to that. On that last point, I had the pleasure of working as a board member and in collaboration with the local management board for Baltimore City many years ago, and we launched as part of that effort something we call Diversion, return from out of state, divert from out of state, a model that brought children back home from out of state residential treatment centers, and with funding that followed. And the state committed to allowing that funding to be programmed and reprogrammed at the local level to create the kind of infrastructure that we're talking about now, local capacity for local beds, as well as community-based alternatives like ACT teams, et cetera. That model was wildly successful beyond even the state's and Baltimore City's imagination, so much so that they had at one point a bolus of over $12 million that they could reprogram for that were savings represented. That model is one that would work and could work, but we have to get state buy-in again to try to begin to redo that to address those issues.
Thank you, Doctor. I see Sean. Yes.
Hi, I'm Sean Latanzio, and I work directly with a lot of the RTC missions here in Montgomery County. And I want to thank Dr. Crowell for mentioning that, because here in Montgomery County, years ago, I worked on the return to divert children back to Montgomery County. And it was very successful because children came with what they call with a backpack of funding that enabled them to get services, and they really amped up the service providers in the county. But getting back to that, now that we have capacity issues in our local providers in the state of Maryland, I have a lot more requests, and so does Department of Health, and so does Child Welfare, for children to go out of state. So with this bottleneck, it's also creating more children to go out of state for residential treatment services. So it's also adding to the out of state capacity as well.
Thank you. And Ms. Chair, I'm going to try to limit my questions to 3 more. This is a tough one because there's so many. But why is it, who pays for them if they go out of state?
For going out of state, it's a combination of issue. If the provider has Maryland Medicaid will pay the residential portion, or Montgomery County Public Schools may pay the educational portion if they have a non-public school IEP. So it's going to depend upon if MCPS can pay the education for the out-of-state placement, as well as Maryland Medicaid has a contract to pay the out-of-state for clinical and residential services.
So they have to send them out of state because there's no capacity here. It has nothing to do, I would assume, with how much you're paying.
Right, it's usually a capacity issue. Or else they've been ruled out from various programs in the county, in the state of Maryland. If the child may be a high risk for AWOL or have other developmental or autism spectrum disorder, they may be ruled out for Maryland RTC programs.
All right, and one, I'm going to do 2 more questions, and how much would that, and I don't know that anyone's going to know this answer now, how much would the reimbursable rate have to be in order for someone to go into business in Montgomery County, or even in the state of Maryland? As much as we want people to be in Montgomery County, if they would just be in the state of Maryland, how much would it cost? How much would that reimbursable rate have to be in order for it to be worthwhile for someone to go open capacities? And there again, you don't have to answer that now, but I'd certainly like to know that answer. And then the last question I'm going to ask for for now. I have a feeling you're not going to be able to get back to me, Mr. Chair, because we're going to run out of time. But Scott Graham mentioned, and he called him an air traffic controller, which I like that, for the EMS 700. Do we know where we are in those discussions and how fast that person could be hired, or have they been hired? Please. Chief Goldstein or someone?
Yeah, I can weigh in on that.
Okay, please, Ben.
Yeah, so we have the framework for the position because we used it during COVID, and I think we could probably revisit this in the springtime as whether we would be able to get that up and running. Certainly by the beginning of the next fiscal year, I think is kind of when we were thinking we'd be able to get up and running. As you're aware, we have our own staffing challenges here, so even one more position is something we'd have to have more discussions about. So we're not really ready to say for sure, but we'd be able to look at it again in the spring.
Sooner rather than later is a good answer. But if you have to divert somebody and it can be up to 20 minutes away, obviously the times, the drop time, et cetera, is going to be extended as well.
So all of that's considered by that EMS 700 position. They're constantly looking at what's available. And if the closest hospital is backed up, whether it's high acuity or a lot of ambulances waiting, that extra drive time actually can get that ambulance cleared faster than going to the closest hospital and waiting.
Thank you. I yield back to you, Mr. Chair. Reluctantly yield back to you, Mr. Chair. So thank you.
No, Mr. Chair, those are great questions, and I appreciate you asking them. And there's a lot more we're going to have to follow up on that, as we said at the beginning, we're not going to be able to get through in this session. And I was trying to frame or think through how to process this in a way that's productive with the 20 minutes or so that we have left, and then lead that into the discussion that we're going to have in a couple of months. And I guess the best way to do it would be thinking about this in terms of short, medium, and long term, acknowledging that there are connections between all of them. But, as we're discussing all of this, and I once again appreciate Dr. Leslie bringing in the story that she shared, this problem is not going to subside, it's going to increase because the challenges that our children, youth, and families, and in particular our at-risk populations are feeling right now, not just through the pandemic, but because of all of the pressures that we are aware of in our world and society, is going to make this all the more complicated. And there were a few things that I hadn't focused on enough on over the last few years, but that I think bear worth repeating. One, just in the short term, the fact that we are more on a blue level than we are not is obviously a huge concern and underscores the immediacy of us addressing those logjam issues that everyone has articulated. The other is, as we talk about substance abuse, alcohol is there and continues to be a huge issue and one that we need to think about and address moving forward. And I appreciated Dr. Kroll talking about our corrections facilities because that is another component to this that adds yet another layer of complexity that is something that we can't avoid as well. But I guess in the short term, I heard several recommendations, and I certainly concur with the notion of, just on a basic level, a public awareness campaign, just to sort of address, what's out there, what's possible, educate our residents about when and how they should be accessing emergency rooms, thus potentially freeing up at least some capacity. I know that I was very excited when I heard about the telehealth and telemedicine pilot that we have going on through fire and rescue right now, which I think is a concrete example of something that may help sort of in that diversion. But if we could spend a minute or two talking about a public campaign, and I'm not sure who's in the best interest to discuss this, maybe we can start with Nexus in partnership with HHS. But there are tools that we have at our disposal in order to be able to educate our public. We've made tremendous strides in educating our public about vaccination awareness, as an example, both at a macro level, but also a grassroots level as well, and have established channels there, communication channels that we may be able to access and utilize in other ways. For example, our minority health initiatives and program have really done remarkable work in these last year and a half, and could be an advent or a tool to be able to get this public education campaign. But who would be in the best position to facilitate that? Where could we, start a cohesive, concrete message that we could then utilize those channels for? And I'll open it up to see Dr. Kroll is first up. Go ahead, Dr. Kroll. Any thoughts on that would be helpful.
So yes, thank you, Council Member Albernos. I think a couple of things. One is we have, I know that the providers, some of the folks on this call have done a lot in terms of promoting health and telehealth and promoting, sending messages out to promote well-being for our community residents. The Minority Health Initiative you talked about is another space. I believe that that Nexus Montgomery represents a good opportunity for us to come together and do some collaborative and collective work on those issues. The department is certainly willing and ready to work on that. My goal for the department is to try to do a broader, to create broader communication channels around all of the work that HHS does. So this fits nicely into that overarching goal for me as well. So be happy to work with Nexus and really other folks as well around messaging and how we do that with the public.
Dr. Leslie?
Yes, I wanted to add to what Dr. Crowell is saying. We have discussed this as a work group because we've thought about the different points of entry for behavioral health care, particularly crisis care. So we've explored Info Montgomery as the website, and we've certainly engaged the county in discussing how it can be the Google of behavioral health services for county residents. In addition, I know the county has a number, but a 240 number. It's not like 911. It is for Medicaid recipients and underinsured individuals. But I know that nationally, there's a drive to have this mental health 911 number. And perhaps if that's something the county is interested in investing in, that may be completely accessible by all, regardless of broadband internet access. But the work group certainly affirms the need to have a central repository of when this happens, try this, because it is really, it's really complicated. And even as a psychiatrist, I can say when looking for services for my loved ones, it's complicated. Yes. And most of us may access our insurance companies, but I know that this is my specialty. It should be easier for me, and I'm telling you it's not. So definitely making it easier for people to access care. I would in a wonderful way. Yes.
Dr. Leslie reminded me of two things. One is that we are looking at, as a result of the work, what we've learned, lessons learned through the pandemic, at how we engage the 211 system, the statewide 211 system, as a resource for the public to access services. And then the larger problem that Dr. Leslie reminds me of is that we have an incredible wealth of private providers in this county, but we don't know often where to access them, how to access them. They often themselves don't know where to go for resources and struggle to find referrals. We've never had a real network of information and resources for the private community. I don't know that it is the role of government to establish that single-handedly, but it may be an opportunity to do something with our boards and commissions and with the boards, the state boards, around developing some kind of regional and or statewide referral resource for the public. That would, I think, be a complement to something like an Info Montgomery.
I appreciate that. That's really helpful. I'd love to follow up on that and see how the council might be able to support those efforts in some formal way, whether through resources or, just to help connect some additional dots. That would be great. Somebody brought up the point, and again, when I went back on my ride along, the same thing happened, and I heard the same thing. There are often families whose loved ones are in crisis, and oftentimes cycling in and out of the system, back and forth, back and forth. And I think it was Ben that talked about working closely with the hospitals on the identification of those specific families to help work further upstream and address the needs of those particular patients who come back and forth. Is there more that we can do there? Because I know there's already collaboration underway, and oftentimes, and I've shared this publicly before. In my own family, we experienced this several years ago with a relative who was in crisis and in and out of the system and in and out of different emergency rooms at different times across the entire county and region, frankly. Can we talk a little bit more about that coordination with families who are experiencing this and what that might look like or what it should look like? Marcel.
Thank you so much for the opportunity. I would just say that, Avital from our fire and rescue department, I believe, spoke about this a little bit earlier. This is really a significant opportunity, but it's of course nuanced as with many situations. Number one would be, I think, really an effort to really focus on who are those, and let's just create a generic number, council member. Who are those top 50? Who are those top 75? Who are those top 100 sort of high utilizer cases within the county that are crossing over all of the representation that we have here on this call, who are impacting fire and rescue and impacting the emergency departments and impacting our agency systems. And it's the same story. If you were to pull up all of our different numbers from our individual hospitals, chances are there would be 50 to 60% of those that would be the same names. And how do we engage them in a way that really benefits the entire county and the community, where we know that they are bouncing in and out of services? And part of the reason why it's a bit nuanced is because particularly we are sensitive to making sure from a privacy and confidentiality perspective, there are even higher expectations as it relates to HIPAA for those who have psychiatric and substance abuse needs. And while I support many of those initiatives and making sure that there are not disparities created by that information being gotten out there, as it relates to the way that we support and provide services, a better level of agreed upon integration and sharing of knowledge around those cases, I think is critical for the success of those residents of our county. And so, again, I think there are some opportunities to try to figure out how do we balance those laws and regulations in a way that really allow for, again, hospitals and public service to really sort of be able to engage and speak openly about these cases, so that we're not providing, in some cases, redundant services. I mean, think about a client. I'll just give an example. There is a friend of ours, if you will, who is a patient that we see on a pretty regular basis, probably just within our system alone. We may see 5 to 10 times a year in the emergency department, probably once every month to every 6 weeks. But the reality is that's only telling the story of how many times they're within the Adventist Healthcare system. Yep. How many times is that same person showing up at Holy Cross, showing up at Suburban, et cetera? And so then there are recommendations and things that are happening at each of those locations about how to provide care. So maybe one psychiatrist and ED physician recommends X med management. Then they come to another location and they get Y med management. So think about that lack of integration and how in many cases, even though you may know that client, that patient, it's almost like the process is sort of starting over again. And so how does that allow for that person to ever really achieve some level of success or stability? So I think, again, some opportunities there to try to balance laws as well as create a bit more of an open dialogue amongst providers.
I knew Avital I apologize, Avital, you were the one that had brought this up. Thank you so much. That's what triggered the question. Dr. Kroll.
So yeah, Marcel talks about an issue that is something we've been discussing off and on over the years. And in fact, Nexus, the Nexus team came together in part to address this issue at one point. The complication is incredible. It is the policy level at the hospital level. It's also the ED docs in the emergency rooms that need to know the policy, need to know that they have permission to talk. It's across multiple hospitals. And that whole issue of privacy, each of those units, each of those organizations has set its own guidance and implement policy around privacy to ensure and protect privacy. And each of those is backed up by a series of lawyers that help to interpret and shape policy. So I see Marcel smiling. It is a complicated process to work through. We had worked through that at least at one level. I do think it is time to revisit that in the wake of COVID. I think the HIPAA has created some flexibility around that, as well as there are some state laws that allow us in an emergency to collaborate and to talk across organizations. And that just needs to be refreshed and I think and re-evaluated in this post-COVID environment that we find ourselves.
Dr. Leslie, and then I'm going to go to Councilmember Rice next to say a few comments. Then I'm going to make some recommendations for part 2 of this discussion, which will be later on this year, but not far away. Dr. Leslie.
Yes, I just wanted to briefly say that it is a huge challenge. We regularly get calls from families, loved ones who want to communicate with their loved one who's in crisis or hospitalized, and we want to involve them, but privacy does limit. I'm just thinking about the Tarasoff duty to warn. There definitely have been laws that have been constructed to allow to protect individuals and the public when privacy and harm overlap. As a practitioner, I certainly am allowed to receive information. So if a family member mails me a letter, I can read it. I just can't confirm that their loved one is in my care. But I certainly encourage loved ones to be involved that way. And as a practitioner, we encourage, when appropriate, our patients to engage their family and loved one support system.
Thank you. I'm going to go to Councilmember Rice next, and then I'm going to make some suggestions for our follow-up discussion. Councilmember Rice.
Well, thank you very much to both chairs, and thank you to all the participants. I'm going to try and jump into this very, very quickly. So when I first ran for office back in 2006, it was because we didn't have a hospital in Germantown. And I felt as though the services that needed to be provided for one of the largest areas in the state, not even just in the county, was woefully lacking. And so now we have both Shady Grove Adventist Emergency Center as well as Holy Cross Germantown that was opened back a little over 7 years ago. I think you guys just celebrated your 7th year anniversary, maybe like a month ago. So congratulations to Holy Cross. But I know that part of the development of Holy Cross was the understanding of expansion. And so my question is to Holy Cross, but to also all of the other providers in terms of whether or not in a hospital capacity, working in a public-private partnership, there may be the opportunity for us to build on your campuses to try and address some of the needs that we're seeing in the community. Because I agree with what Chair Albornoz has said, and basically everybody else has said, look, this is only going to get worse. It's not going to get better. And I fear, while Councilmember Albornoz has talked about alcohol, I actually fear that folks who self-medicate via marijuana, and marijuana soon being legal, is going to make sure that people do not get the help they need and instead continue to self-medicate. I don't have a problem with the decriminalization of marijuana. I feel as though that's something incredibly important. I do have a problem with folks not getting the help they need for the problems that they have and continuing to utilize other methods that aren't approved by a doctor in terms of a plan to help them with those mental health issues they need. And it's not, and let me just close by saying this, and then I'll just open it up to folks. Let's think about who the folks are that are using marijuana. And I just want to just jump in on this one because it's our young people. Oftentimes our young people who are impoverished. Oftentimes our young people who are experiencing pain and challenges in their community, Black and brown, who are the ones who are utilizing this. It is a call for help. It is not an independence. It is not a, fad. It is not something, it is actually something that's indicative of a much larger problem that exists. And we see it then magnify itself in other kinds of ways in these same communities as well. And so I think that we're at the canary in the coal mine here. I think that we really have to get something right now that really starts to address the issues that our children are facing and experiencing. And so my hope is that working together with our hospital partners and with our private providers and with public, we can come up with a robust kind of pilot program to help address some of these issues. And so anybody, if Holy Cross wants to jump in first, because I know, again, that part of the plan was that there would be space that would be available for some sort of expansion at some point. And so the question is that something that may possibly be in the works?
Not hearing anyone.
Okay, this is Van Coots from Holy Cross. We're on double secret mute here. I'm sorry.
Yep.
First and foremost, we have a state issue that we have to deal with. The state will tell you that we are adequately bedded, if not over-bedded, in behavioral health. So we have got to figure out where those beds are, because I certainly don't know where the beds are. They're not here in Montgomery County. There's no question about that. The second is, what is the state's plan? The state says that they recognize that there's excess capacity in the state, and there's a new plan coming out as to what to do with those beds. We know some of those beds, for instance, one unit here at Holy Cross is being mothballed because we're a special pathogen assessment hospital, is for the next superbug that hits, to be able to rapidly expand for that. But yet there are beds in other places that are being decommissioned that could be utilized for things like this. I think a big piece of this is also what goes on in the community, because if we care for someone acutely in the hospital, they still have to have care out in the community once they're discharged. Otherwise, there's a recidivist. They wind up bouncing back and forth. And then there are so many different categories. There are adults who have autistic adult children, and sometimes they drop them off at the ED simply because they need a respite. They need rest themselves from the care of that autistic child. So there are a lot of this is a multifactorial thing. And on top of that, we're now in the worst nursing crisis we've ever had before. We thought behavioral health nurses were hard to get. Imagine now when we can't get any nurses, how we're going to put together additional behavioral health care. So we're all for it. We would love to see something built up on the campus at Montgomery College in Germantown. There's plenty of space there to build things. Maybe you need something up county as well as down county both to really help handle the population. But right now, Stabilization Center is the first thing, and things in the community, and people in the community who will do charity care and actually take Medicare, Medicaid, VA care, and TRICARE, which a lot of the private providers will not take.
Mr. Chair, if I may, just based on that, I would just ask that for us, because we have a General Assembly session that is coming up, that we work with Mel. I know you're about to do some next steps, so we just ask that we address that. I'm sure that the answers would be the same, and I know that we're short on time, so I apologize to the other hospital partners, but certainly one in which we can explore that and explore what legislation we need to be able to free up to allow our hospitals to be able to think innovatively about how they can help us in conjunction with HHS and others to address the need. So thank you, sir, and thank you.
Thank you. That is the perfect segue, because I think that was one of the principal recommendations I had as well. And we should probably start with that to make sure we have the opportunity to get through it and not miss the opportunity to add this to the priorities of the council among our delegation as they go through their advocacy efforts in a variety of different fronts. So, there in addition to that, and I would, a little bit of a homework assignment for our colleagues and friends here. We've identified some of the state policy issues and barriers that are, for whatever reason, impeding our ability to fully address these issues. Some of those are just budget challenges. Some of those are general philosophical policy challenges. But that leads me to the second point, which is recruitment and retention of staff, which is a problem across the board. And we did not have an opportunity to expand this morning, but I'd like to also spend a fair amount of time in our next session discussing some of the best practices with regards to recruitment and retention that each of the hospitals are undertaking, as well as our team here within county government, because we're experiencing this in county government as well, and see what, if any, steps that we can take. And let's be bold. This council recently proposed legislation to provide a tax credit to first responders, in part because we couldn't expand it to other categories. But we're at a critical juncture in terms of recruiting first responders here in our county and within our community. And the same is true in other key categories. Without these categories of positions, it's going to really significantly impede our ability to provide the kind of public health infrastructure that we know we need. So would love some recommendations and solutions in that space. And then I put, I think, maybe 7 or 8 stars around the Stabilization Center, which everyone has mentioned multiple times. And that is something that clearly there's a collective agreement could be an important solution in helping alleviate some of the challenges, specifically in the behavioral health space. But I also want to hear from our hospitals as well in the next session. We've now surpassed 1.2 million people in Montgomery County. We are a very large jurisdiction. And the fastest growing demographic we have in our population is our aging population. And that's just one important data point as we think about realistic capacity and infrastructure within our hospitals. And you guys are doing the best you can with the resources you have. And I would like to just start thinking about, that overall capacity as a whole. I know this is a conversation Nexus has often, but it's something that I'd like for us to talk about in a follow-up session too. As Councilmember Rice noted, in Germantown and in the upper part of the county, the infrastructure is for need is significant. And there are opportunities that are out there that we shouldn't miss, that we should take advantage of as well. So this has been an incredibly robust session, and I can't thank all of you enough. We will schedule the part 2 before our December recess. So look out for some proposed dates and times as soon as possible. But I want to thank Chairman Katz for helping us schedule this as quickly as we were able to, and especially thank Linda McMillan, Beth, and many others who helped facilitate this dialogue and put together this very esteemed panel this morning. So thank you all so much. We are adjourned for now, but more to come.
Thank you.